Welcome to the anatomy module here at the University of Sunderland with me, Ivan Whitfield. My background is in sport and rehabilitation therapy, and through my time in clinical practice and teaching I've had the good fortune to study the structure and the function of the human body for a number of years. In these videos I'm using the fantastic Complete Anatomy, and you can access this same resource through your university account. Today we're starting a series of videos on the lower limb, and specifically today we're going to be looking at the hip, the pelvis and the thigh before we move on to the knee, the lower leg, or the leg as we call it, and the ankle and the foot. So let's jump straight in. So here we are looking at the lower limb in its entirety. You can see the lumbar spine, the sacrum and the coccyx. Let's just zoom in a little bit and get a picture of what we're doing in a little bit more detail. Let me move this over here. So we're going to look at the pelvis first. Let's get rid of some of the other structures in the area. We'll hide the sacrum, and we'll hide the coccyx, and we'll hide some of those vertebrae. Get rid of those facet joints. This of course is the femur, and we'll cover this in a little bit more detail later on. Let's get rid of it for now. So here we are looking at the pelvis. Now the pelvis itself is actually one of three bones. Joined together we call it the pelvis. Pelvis means basin. It's actually maybe more correctly known as the innominate, and that simply means there is no name for it, because as you look at it, it's very, very hard to describe, almost impossible to describe. Let me just get rid of that as well. It's actually made up of three bones. Those bones being the ilium, the ischium and the pubis. And if we were to look at the acetabulum, which is the hip socket itself, sort of the socket of the ball and the socket of the lower limb, if we look at that, we could sort of draw, if you like, a very brief Y shape in here, which actually would represent the three bones coming together. And these sort of fuse once you get to adulthood, and certainly probably into adolescence. These bones have started to fuse, and if not completely fused by the time you're an adult. There's no cartilaginous joint at all in them. Let me just get rid of that. We'll get rid of the pen. So by the time you're an adult, these have completely fused, and you can sort of see the faint outline there of where the pubis is. In fact, there's another joint down at the between the ischium and the pubis down here as well. So familiar ourselves with the areas of the pelvis, because there's lots of bony prominences and outcrops, and they're all important because essentially that is where muscles attach. Let's start here at the front, and if we take our pen again and we just highlight this area here, this is known as the anterior superior iliac spine, or the ASIS, or ASIS as some people say. This is a strong attachment point for groups of muscles. Just below it here we have the anterior inferior iliac spine, so we have the superior and the inferior. Again, another crucial muscle attachment point. If we've got an anterior, we've probably got a posterior, and right here we have the PSIS, or the posterior superior iliac spine. Coming down to the front, we've got the pubis, and if I just quickly take the pen off and spin round, you can see that pubis actually in 3 dimensions. You can see quite clearly how it sort of sticks right out of the front, and in fact just on the inside in this area here we've got an articular surface where there's a cartilaginous disc. So this is a cartilaginous joint where the two bits of the pubis effectively come to form a joint. Underneath this we've got underneath we have the inferior pubic ramus, and above it we have the superior pubic ramus. Now these form a continuous joint, and you can almost in the middle of that see a very faint joint line with the ischium, and the ischium is this bone here. This sort of bit that sticks out at the bottom is effectively your sit bones, as some people call them, the ischial tuberosity. At this point you can see a large notch here and a smaller notch underneath. So this large notch, which is in this area here, is a greater sciatic notch, and down here we have the lesser sciatic notch. Now the sciatic nerve, as it leaves the spine from the plexus, actually splits and fills these two spaces. Again, very, very large nerve bundle associated with many different pathologies. So let's look at the acetabulum in a little bit more detail. You can see there's a very deep socket, and if I just sort of shape it around a little bit in 3D, you can sort of see how deep it actually is. Very different to the shoulder, which has a very shallow socket. The glenoid is very, very shallow, but we sacrifice stability for range of movement at the shoulder. Down at the lower limb, which is the locomotive limb, we need the stability. We're bipedal humans, we need to stand on two legs, and therefore we need a bit of stability down here. We've got muscles and we've got ligaments which assist in this, but the bony congruity is important. Looking at that in a little bit more detail, you'll see that there is a sort of an articular surface which is C-shaped. Now the whole of the socket isn't actually covered in that articular cartilage. That's because it really only exists where weight bearing occurs, and that's not uncommon across many joints. As previously mentioned, it's a ball and socket joint. That means it's multi-axial. So we have 3 planes of movement and 3 axes. If we just reset the bones, you can see that the femoral head sits nicely into that socket, and I just quickly highlight that area for you there. So you can see there that the femoral head is sitting nicely in the socket. And the femoral head, of course, has a very good articular surface. So moving on to the femur, we've got some key areas to identify. We'll just temporarily hide the bones of the pelvis. So the femur itself, like I said, we've got the femoral head here. We've got the femoral neck, which is in this area here. The greater trochanter and the lesser trochanter, which are important muscle attachment points. Now it's fairly important to be aware of the blood supply in this area. If we add in our arterial system to this, you can see very clearly there are 2 large arteries which are passing around here. These are called the Circumflex Arteries, and at this end we've got the ascending branch of the lateral, and if we can add another layer in there and then do a slight bit of rotation, you can see on this side we've got the medial circumflex artery. Now in trauma where there's a fracture of the femoral neck, it's very obvious that the blood supply, or the entire blood supply almost, to the femoral head and the femoral neck will be interrupted, and this leads to avascular necrosis. So in nearly all situations where there's a femoral neck fracture, the likelihood is that there's going to be operative procedure and there's going to be prosthesis replacing the femoral head and neck. So we've removed all of that blood supply and we're back at the bony structures of the hip. Now if we just add in some connective tissue here, you begin to get an idea of how the capsule and the ligaments develop. What we have as we add these layers in is quite a significant large bundle of ligaments supporting the hip. And this is important to understand. Well, it's important to understand why these exist and what they're doing. You can see from the shape of them, we've got the ischial femoral ligament at the back, and you can see how the fibers begin to sort of curve and twist. If we move around a little bit and spin this on its axis, and we look at the iliofemoral ligament on the left, and then we examine the pubofemoral ligament, you can see the way they're shaping, especially this ligament here, the iliofemoral ligament, the way it shapes, it's almost winding up. So if you can imagine, if evolutionary context, being on all fours, these muscles, these ligaments would be reasonably lax. Move into a bipedal stance and these ligaments sort of tighten and wind up, and this is no coincidence. It's important that we have other support for the hip joint other than muscular. This saves energy and it saves muscle bulk, which makes us more agile and more flexible. And so the winding up and the tightening of these as the hip moves into extension means that we can sit quite comfortably in an upright position with minimum energy use. Now I've removed some of these ligamentous and capsular structures, and what you can see that we're left with here is this rim of cartilage here, which is the Acetabulum Labrum. The labrum is a soft tissue cartilaginous ring, if you like, which is there to deepen the acetabula still further and adds to the stability. Pathologically, it's often damaged, especially in sport, and it's something that you should be aware of, and you probably should look into in a little bit more detail. And I would say overall that is a key learning point that you need to just revisit and have a look at the pathologies that are associated with the labrum. There are specific tests that can be done to identify, while it's not completely sensitive and specific, can point you in the right direction and away from other issues in the area. If we just move to the other end of the femur, we can see the articulation with the tibia and what is affected with the knee joint, which we'll cover in later videos. I'm just going to remove some of the connective tissues. So this distal end of the femur, we can see the medial and lateral epicondyles, the medial and the lateral condyles. At the front here we've got the patella, and I'll just remove that so we can look underneath, and we can see the articular surface quite clearly. If I just remove the tibia as well, and we'll move the fibula, we can look at the articular surface of the femur in a little bit more detail, and you can see there's a little bit with foot coming in there, sorry. You can see that there's a little bit more cartilage medially. In standing, that's because most of the weight goes through the medial side of the knee. And you can also see that there is and I'll draw on here, you can see that there's a sort of a dip here, and that's the groove that the patella tracks through. If we look at the posterior view of the femur, we can see the very back here there is what is a very visible line or ridge. If I just rotate slightly, you can see it's a little bit more dimension just there. This is a very important muscle attachment point, in fact, where the quadriceps muscles attach, the lateral and the medial vastus group. This is called the linea aspera, which literally translates as rough line, and it's a very sort of pitted, rough area of the bone, which increases the sort of surface area for strong muscle attachments. And the vastus medialis and vastus lateralis muscles attach on the medial and lateral side respectively. So we're just going to move back up to the pelvis again and just look at some of the structures in and around the anterior view. If I just add in a few bits of connective tissue again, there's a couple of structures I want to highlight. This is the interpubic disc that I spoke about before, and forms the cartilaginous joints between the two bones of the pubis. Just adjacent to it, and this is sort of palpable if you lie on your back and stretch the tissues, put your hip into slight extension. This is quite palpable, strong ligament. It feels almost bony. It's that thick and strong. This is the inguinal ligament, and you can see it's emerging here from the pubis and attaching onto the ASIS. This forms the border of the femoral triangle, and femoral triangle is an important structure to be aware of as well. If I just add in some muscles into the area, and we'll get some superficial muscles in, because what we need is our sartorius and our adductor longus, and these three structures form the borders of the femoral triangle. And why is that important? Well, if I was to add in some of the major blood vessels, and we add in some nervous tissue, and this is a very vulnerable area in terms of damage. So we'll just remove some of these tissues again, simplify our diagram. We're going to move on in the next video and look at the muscles. You can see that there are many muscles in the area. There's a lot to go through, so we'll do that in one go in a separate video. But for now, take your last look at the hip. Look at its unique design, and very unusual design, to be honest. But it's extremely fit for purpose. The forces, the way the bones align, match the biomechanical forces that go through the area. It's relatively free of pathologies, but when it is damaged, there's a lot of structures to be aware of, and traumatic incidents or high trauma impact can be catastrophic in this area because of the blood supply. So in a separate video, we'll cover the blood supply and the more complex neurology of the area.